Good morning, everyone. Today we are going to have a lecture about the instrumental evolution of the heart function. Today is our plan. Heart sounds and their physiological mechanism. Diagnostic value of auscultation and phonocardiography. The integral electrical vector of the heart and its dynamic during the cardiac cycle. Electrocardiographic leads and their axis of on the frontal and horizontal plane, and main parameters of the normal ECG and their physiological interpretation. Let's start about that. The heart walk mainly is described as such phenomena which is called heart sounds. Heart sounds could be measured by the different methods. The first one it is auscultation by using such device which is called stethoscope, or another one which is responsible for record electrical part of the sounds, and also the electrical graph of the sound, and also their loudness which is called phonocardiography, and which is used such device which is called phonocardiography. First of all, let us discuss about the stethoscope. Stethoscope have such part which is called belt. It is used for to hear low pitch sounds. Also, it is used for mild diastolic murmur and mitral stenosis, or S3 in the heart failure. The diaphragm filters out of low pitch sounds, highlighted high pitch sounds used for analyzing the second heart sound, ejection of mid-systolic leaks, and for the soft but high-pitched diastolic murmurs and aortic regurgitation. Before we are going to start to talk about the heart sound, let us generally describe the mechanism of the appearing. The first sound appears due to the closure of the atrioventricular valve. The second sound appears due to the closure of semi-lunar valve. S3 sound is appear due to the rapid filling of the ventricles. So, in this slide, you could see the chest and of the man and the points which is given for best hearing of the function of the aortic, pulmonary, or bicuspidal wave or tricuspidal wave. Let us discuss their projection. So the best place for detection of the function of the pulmonary wave will be the second intercostal space on the left sternal body. For aortic wave, it will be the second intercostal space of the right sternal body. For bicuspidal wave, it will be the 5 intercostal space on the line media clavicularis on the left sternal body. For tricuspidal wave, the best place for hearing will be 5 intercostal space on the right sternal body. Besides that, there is a Erb's point. It's a point for the best hearing of the S1, S2, and S3 sounds. It is located on the third intercostal space on the left sternal body. So, the first heart sound, which is going to be heard like a lap, is marks the beginning of the systole. It's related to the closure of atrioventricular waves. It means the closure of the mitral or tricuspidal wave. It loudest at the apex and the lower left sternal body. Another sound S2 sound, which is called dub sound. The second sound marks the end of the systole. It's related to the closure of the semilunar waves, which are present by aortic and pulmonary waves. Mostly it is loudest at the base. For the second heart sound, the diaphragm is available with a stethoscope, usually best placed at the base. So now let us hear the normal heart sound. The first sound will be lap, and the second sound you're going to hear like a dub. So please. Okay. The next sound which appear after the third one, it will be the third heart sound. It's heard in the early diastole. It's mainly caused by the rapid filling of the ventricles by blood. So it will be good. It will be good like lapped up by. It can be sort of a sound which is generated when the ventricle is forced to the dilated beyond its normal range because the atrium has overload volume, as seen in the congestive heart failure, which is most common cause of the third heart sound. Mainly, it's normal for people who are young, less than 30 years old. Also, this kind of sound is heard in people with the heart failure. S3 is a low frequency and thus best heard with the bell on of the stethoscope at the apex, while the patient is in the left lateral decubitation position. Now it is here the third heart sound. Okay. So the first heart sound is low frequency sound, incipient late diastole. Mainly it will appear before the S1 sound. It is caused by the atrial kick into the non-compliant ventricle. It is seen in patients with a stiffened left ventricle resulting from the conditions such as hypertension, aortic stenosis, ischemic and hypertrophic cardiomyopathy. In patients with mitral regurgitation suggestive of acute onset of regurgitation due to the rupture of the chordae tendineae that anchor the vulvar leaflets. So let us try to hear and to make the difference between of this fourth heart sound. I'm sorry. Now, beside normal S1, we could hear abnormal S1. It means sometimes it could be very loud. This happened during the mitral stenosis, during fever after physical activity. Also, sometimes S1 could be soft. It's happened mainly in case of the heart failure when people have a low cardiac output, in the condition of the tachycardia, and also during severe mitral arrhythmias caused by the destruction of the valve. Also, we have the abnormal S2 sound, which could be loud in such cases like systemic hypertension, dilated aortic root, pulmonary hypertension. Sometimes it could be soft in situation of the calcified aortic stenosis. Beside abnormals S1, S2, the most pathological variant, it is the appearing of the murmurs, which mainly happen due to the insufficiency of the valves, which will lead to the regurgitation, means to the backflow of the blood, or due to the stenosis, or it means when the valves are going to be narrowed, and as a result, ventricles or atriums requires a lot of force and energy to pump blood against the stenotic valves. Sometimes murmurs could appear also not due to the defects of the valves, but also in case when we have the ventricle septal defect or atrial septal defect. Let us discuss each of these cases. So murmur has assessment. We need to note where it is heard best and where it is irradiated. We need to try to discern if the murmurs occurs in a systole or diastole by timing against the S1 and S2. Also, we need to note the sound of the murmur. Is it blowing or grating? And note the intensity of the murmur. Let us go further. So also we could divide murmurs on systolic murmurs. The example of systolic murmurs, it could be mitral regurgitation, tricuspidal regurgitation, aortic stenosis L, and pulmonary stenosis. In case when we talk about the aortic stenosis, it's this murmur will appear between S1 and S2 sound. Mostly this happens due to the inability of difficulty of left ventricle to pump blood to the aorta due to the stiffness of the aortic waves and due to the inability to open normally during this system. So let us hear that sound.
It causes
Systolic murmurs also happen during the patent ductus arteriosus. It means when the blood oxygenated blood will mix with deoxygenated blood. So blood from the aorta will mixed with deoxygenated blood of the pulmonary artery. Patent ductus arteriosus occurs in about once in 2,000 of infants. This murmur is best heard over the upper left sternal edge and associated with the thrill, and is characteristically continuous and machinery-like. Ventricle septal defect is one of the most common congenital heart defects. It's happened due to the defect between two ventricles. It's usually best heard over the tricuspid area or the lower left sternal border, with radiation to the right lower sternal border because it's area which overlies this defect. This is also one type of the systolic murmurs, diastolic murmurs. The example of the diastolic murmurs, it is aortic regurgitation, pulmonic regurgitation, mitral stenosis, and tricuspidal stenosis. First of all, let us discuss about the mitral stenosis. As you could see in this picture, during the mitral stenosis, the first sound is going to be heard very loudly. This happens because when the mitral waves are going to close, and this process will be very loud. That is why S sound will be loud. And after S2 sound, we are going to hear such loud, which is called like dar. So let us hear it. Aortic regurgitation. Mainly this happened after this S2 sound. It means that the semi-lunar waves should close. But due to the veil insufficiently, they will not close properly, and so as a result, blood will return back to the left ventricle. So the sound is going to be heard after the S2 sound. Let us start to hear it. Okay. So, phonocardiography. Phonocardiography is such kind of method which is used for recording of electrical part of the sound, but also there is present a microphone which helps to detect this, which helps to hear that sound. Heart sounds, but nevertheless we also will receive the electrical recordings of this sound, which is present in this slide. So normal phonocardiography, you see how it will be recorded, how S1 is going to be recorded and S2, and the projection of the of the aortic veil, the same how the sounds S1 and S2 will be recorded. Okay, now let us go further to the next part of our lecture, which is related to the ECG. So let us discuss what is the ECG. Electrocardiography, it is a recording of the overall spread of electrical activity through the heart. The electrical current generated by the cardiac muscle during depolarization and repolarization spread into the tissues around the heart and are conducted through the body fluids. A small part of this electrical activity reaches the body surface, where it can be detected using recording electrodes. The record produced is an electrocardiogram, or the abbreviation which is called ECG. So, the history of the ECG machine. In 1903, William and Holland it's a doctor and physiologist, invented the first practical electrocardiogram and received the Nobel Prize in the medicine in 1920 for it. Nowadays, we have another variant of electrocardiography machine, which is a computerized, and also we could receive not only the electrical record of the electrical record of it, but also we could receive the interpretation of that ECG. So, before we are going to start, we should stop on the ECG graph paper, which are going to be recorded and discuss about the standard calibration which are present. So mainly the ECG graph paper have two values. It will be described in two values. It is amplitude, and which will be measured in the millivolts, and time, which is going to measure in the seconds. So the large box which is going to be present in the ECG strip, its amplitude, it will be about 0.5 millivolts, and it will consist of the 5 small boxes, so it will 5 millimeters, and its time, how much time is durated, will be 0.2 seconds. Inside of this big or large box, we are going to have 5 small boxes, and one small box will have amplitude 0.1 millivolt, and it will durate about 0.04 seconds. This value we are going to use further in case when we would like to measure the amplitude and the time speed of the each complex of the ECG. I mean X-PQRST complex. So before we receive this ECG, first of all we need to place the electrodes. So where are we going to place the electrodes? First of all, we are going to place them on the limbs. So on the right arm, we are going to place right electrode. On the left arm, we are going to place yellow electrode. On the right leg, we are going to place black electrode. And on the left leg, we are going to place green electrode. Besides this, we have the 6 chest electrodes. V1 will be put it on the first intercostal space right sternal border. V2 it will be fourth intercostal space left sternal border. V3 it will be midway between V2 and V4. V4 it will be fifth intercostal space left medial-clavicular line. V5 it will be level with V4 in the left anterior axillary line, and V6 it will be the same level with V4. It means 5 intercostal space in the left mild axillary line. Mainly, each of these electrodes have their pull. One of them will be pulled, will have positive pull, another will have negative pull. So the lead is responsible to measure these electrical differences between two electrodes. So leads could be bipolar, it measures this electrical potential of the heart between two electrodes, or unipolar, it's measure of the electrical potential of the heart between one active electrode and one constant electrode, which mainly is equal 0. Generally, there is a 12 leads, 3 standard leads. Let us discuss here. 3 standard leads. The first lead it will be between right arm and left arm. The second lead will be between right arm and left leg. And the third lead it will be between left arm and left leg. Besides this, we have augmented leads. It means, in this case, we are going to measure electrical potential between active electrode, which is positive, and the constant, which is going to be connected to the negative pole. So as a result, they will be augmented. What kind of augmented leads we have? It will be AVR, which will be which measures the electrical activity of the right, related to the right arm, AVL, which is going to be related to the left arm, and AVF, which is going to be related to the left foot. Besides this, we have 6 unipolar thoracic electrodes, which also are called precardiac leads, and mainly their position we discussed further, where located V1, V2, 3, V5, and V6. So, let us discuss about the concept of the integral heart vector. According to this concept, excitation of each individual cardiomyocytes can be considered as elementary electrical vector, which has certain direction and magnitude at each time point. The elementary vector reflects potential differences between excited and unexcited cardiac fibers. A geometric sum of these elementary vectors forms the integral heart vector. So let us discuss the integral heart vector, how it will be presented in the ECG. Dynamics of integral heart vectors during the cardiac cycle. So, first of all, we receive the excitation on the atriums. This excitation will be spread through the atriums. This will lead to that, it will mean that the main electrical vector of the atrium will be directed to the left, forward, and downward position, and as a result, we are going to receive the P wave. After excitation of the atriums, in the next step, it will be present by excitation of the intraventricular septum and the ventricles. So excitation of the intraventricular septum will lead that the main vector, integral vector, will be directed to the right, forward, and upward position, and it will be described by the wave Q. The main ventricle vector, which is going to be present and responsible for excitation of the ventricles, it is the R wave, which will be directed to the left, downward, and forward position. The last one, which describes the depolarization of the ventricle, it is the S wave, and the vector of the S wave will be directed back and to the right and left, left position. And the last one, so as a result, we're going to receive QRS complex, which is related to the depolarization of the ventricles, and the last one, which describes the repolarization of the ventricles. This vector is going to be directed to the left, downward, and forward position, and it will reflected by the T wave in the ECG. So generally, we are going to receive the PQRST complex. The shape of ECG in a different leads. ECG waveform is the tracing of the projection of integral heart vector on the lead axis. Positive going deflection is recorded in the projection and refers to the positive part of the axis. Negative going deflection is recorded in the projection, refers to the negative part of the axis. Because of the different axis angles, each vector gives a different waveform of ECG for different leads. So you could see even here that in the different that ECG waveforms will be different in different kind of the leads. When we talk about the now to stop on the understanding of ECG wave. So if a wavefront of depolarization travels towards the positive electrode, a positive going deflection will result. So it will be positive complex. If the waveform travels away from the positive electrode, a negative going deflection will be seen. So you could find here the negative complex. Now we are going to have the complex PQRST, and we are going to discuss which wave will be responsible for excitation of what part of the heart. So P wave, mainly it's responsible for atrial depolarization. Vector is from the synoatrial node to ventricle node. Then the P wave amplitude should be about less than 0.2 millivolts, and it should durate about 0.06, 0.11 seconds. And as it goes, it will be PQ interval, which will PR interval or PQ interval, which will start from the beginning of P and will end at the beginning of Q. This time during which for electrical impulses which will take travel from the sinus node through the AV node and entering the ventricles. Mainly the PQ should durate about 0.12, 0.20 seconds. PQ segment, it's at the end of the, you will measure it at the end of the P value and before the beginning of the Q wave. Electrical conduction from the AV node to the bundle of His and to the bundle branches and then of the Purkinje fibers. Q wave. Q wave should be the size of the Q wave should be only 1/4 of the R wave, the main ventricle wave. Its duration should be about 0.03, 0.04 millivolts seconds. I'm sorry. The next wave, which is mainly describes the depolarization of ventricles, will be R wave. Its amplitude could be different. It could be from 0.8 to 1.2 millivolts. After R wave is going the S wave, which continues the depolarization part of the ventricles. After that, we will measure ST segment. It's described depolarization of ventricles, and it is isoelectronic. And the last one wave which is responsible for repolarization of ventricles will be called T wave, which is present here. Mainly T wave should be positive in the first, second, V5 with 6 position. In the leads, I'm sorry. In AVR, it's going to be negative. Generally, the duration of QRS T complex should be about 0.34 to 0.45 seconds. So here in this slide is presented which lead is responsible for describing information from one kind of part of the heart. For instance, the first lead is responsible for lateral wall of the heart. The second lead is responsible for inferior wall of the heart. The third one will reflect the function of contraction of the inferior wall of the heart. Augmented leads. AVR doesn't have no specific area. AVF, the same as it will be reflected the function of the lateral wall. AVL, the inferior wall. And what about the precardiac or chest leads? So V1 is responsible will be for the septal wall, is the same as V2. V3, V4 will be responsible for anterior wall, and V5, V6 is responsible for lateral wall. This is very important to identify and to know which kind of lead is responsible for characterizing the electrical activity of each part of the wall of the heart, in case when we are interested to put the diagnosis like a myocardial infarction, which could happen in a different part of the heart. About this, we are going to discuss it later. So here you have the ECG example of the 12-lead ECG. Here is present the first 3 standard leads, first, second, and third. Also 3 augmented leads, AVR, AVL, and AVF, and the 6 from V1 to V6, the precardiac leads. Also in the ECG trace, you could identify the heart rate, which is ECG device is measurement independently. The duration of the RR, the QRST, and QT complexes. So when you receive the ECG, you should identify several points. First of all, you should identify if the rhythm is regular or irregular. How you are going to do this? To identify if the rhythm is regular or irregular, you need to count the distance between RR complexes. The distance between these two RR complexes and another RR complexes in one lead should be equal. Mainly, you could do this by the line. So you could measure the distance between these complexes by the line. If it is similar, so you will say that the rhythm is regular. If it is not similar, you will say that the rhythm is irregular. The second point, you should count the heart rate. He is giving you the formula how to count heart rate. You should 60 divide on the RR distance in millimeters and multiply on time. So if you have the mainly you will have the ECG paper graph with 25 millimeters per second. So you will 60 divide on RR distance in millimeters. So you need to count the distance between one R and second R in millimeters. So we know that the big box is a 5 millimeters. So first, it's easier first of all to count big boxes. We have 1, 2, 3, 4 big boxes. For big boxes, it will be 20 millimeters. And also we have one small here small here box and 3 here. So 4 small boxes. So generally we have 25. The distance between one and the second R will be 25 millimeters. And then you should multiply on the time, which presented in seconds. But as we know that it is a 25 millimeter per second strip, so we need to multiply on that on the time of the small box. We know that in a small box will have 0.04 seconds. So generally when we calculate as the result, we are going to receive 62 beats per minute. The next step is to identify the heart axis. About heart axis, I'm going to explain a little bit later. And you should analyze of PQRST complex. First of all, you need to find the P complex. P wave. If you see the P wave, you could say that the rhythm is sinus. Secondly, you should measure its amplitude. As we described, it should be less than 0.2 millivolts. We know that the small box is about 0.1 millivolt. So logically, this one is less than 0.2 millivolts, and its duration in seconds, which should be about 0.06 second to 0.11 second. You see, at the beginning to that, it will involve one small boxes and like about the half of the second one. So it will be less than 0. It will be the value will be between 0.6 and 0.06 and 0.11. Next step, you should measure the PQ interval at the beginning of P to the Q, which shouldn't be more than 0.12 to 0.20 seconds. Then measure the time of the QRS T complex and the amplitude of the T value and R value. So now let us go to talk about the cardiac axis. To determine cardiac axis, you should look on the QRS complex on the first, second, and the third standard leads. So if in the first lead you will have the positive QRS complex, the same you will have in the third and the second, and the third lead, you will say that the cardiac axis will be normal. If in the first lead the QRS complex will be negative, and on the second and the third is going to be positive, you will talk about the position of the heart, it is the right axis deviation. And another situation when you will identify positive QRS complex on the first lead, but negative on the second and the third, so you are going to talk about the left axis deviation. Now let us look on the clinical on the ECG strip and discuss it. So you could see that the first on this ECG strip, the QRS complex is positive in the first lead, is negative, in the second lead, and negative on the third lead. So the heart have the left axis deviation. In this, you see that it will be negative in the first lead, it will be positive in the second and the third, so it will be right axis deviation. In case if in all leads will be positive QRS complex, you will talk about the normal position of the heart. Now let us just talk about a little bit about the diseases, what kind of conditions which you could identify on the ECG. So diagnostic of the myocardial infarction. To put diagnostic of myocardial infarction, you should have several criteria. So first of it is elevation of the ST in 2 millimeters in the chest leads and in 1 millimeter in the lymph leads. And also you should have a Q wave, which should be more than 0.04 seconds, should be very big. Pathological Q wave are a sign of the previous, also could be a sign of the previous myocardial infarction. So in this situation you could identify, so here is a normal ECG, and here you could see the elevation of ST complex, which is bigger than to the higher than the isoline, and in this situation Q does not appear, but further I will show you ECG where it's going to appear. So ST elevation in myocardial infarction will be called STEMI. At the beginning, you will identify the pronounced T wave initially and also ST elevation. On the 24 hours, you will identify the depressed of the R wave, pronounced of the T wave, and you see the pathological Q wave, which may appear within hours and may take greater than 24 hours. In the day 1 and 2 after the appearing of the clinical symptoms and appearing of the STEMI, you will see exaggeration of the T wave, you could see here, which is continuous 24 hours, and also very high ST elevation. Days later, T wave inverts as the ST elevation begins to resolve. You see, ST will become smaller and T wave will be inverted. But nevertheless, Q wave, you could see that it will increase in days, and even weeks later we are going to receive this Q wave, which will stay, but T wave will return to the normal position. Here you could see the anterolateral myocardial infarction, and on the V2 we have elevation of the ST segment. The same we have elevation here presented, so it will be higher than the isoline, and also you have a pathological Q, which is very good seen here, and right here. So ST elevation and Q wave, it's mainly two main points which describes you the myocardial infarction. The same situation will be here. In this case, we're going to have inferior myocardial infarction due to the elevation of ST on the second, third, and AVE leads, which are responsible for the inferior wall of the heart. And also you can see inverse of the ST value and increase of T value in the this one in the chest leads. So myocardial ischemia is described ST depression is more suggested for myocardial ischemia than infarction. So we could see here identified here in this values ST depression to below the isoelectric line. And this depression could be about 1 millimeters. And also we could identify the Q long QT interval. Okay. Left ventricle hypertrophy. is determined by the Sokolov line criteria when S wave in the V1 plus R in the leads V5 over 6 will be more than 35. And Cornell criteria when S in the V3 and R in the AVL will be more than 28 millimeters. So you should count the size of S and R if it will be more than 28 millimeters for man or 20 millimeters for woman. In this situation, we could put the diagnosis of the left ventricle, the hypertrophy. For right ventricle hypertrophy, we need to have such criteria like right axis deviation, and in V1 R should be more than S1, and in V6 S should be more than R. So you could find here that in the V1 we have very high R and very small S, and in VV and V6 you could see that we have very small S, very big S and very small R. So it will be the right ventricle hypertrophy. One more situation could be defect due to the arterial fibrillation or ventricular fibrillation. In case of arterial fibrillation, mainly you will see the irregular rhythm and no visible P waves. So this is like we couldn't describe, this will not be the P waves, it's going to be the F waves, and you even could see that the distance between R will be different. So irregular rhythm and no visible P waves is the main diagnostic criteria for atrial fibrillation. Thank you for your attention.